Okay, now let's turn our attention to a really important topic in the heart, and that is the cardiac conduction system. In order for us to understand the cardiac conduction system, why we have it and how it works, it's useful to start by thinking about what makes cardiac muscle similar to and different from skeletal muscle. So, the similarities, there are many similarities between cardiac and skeletal muscle. The most important ones being they both have thick and thin filaments, they both have a mechanism so that when those filaments slide over one another, it generates tension, contraction. They both have polarized membranes. In both cases, when those membranes depolarize, it results in a sequence of chemical events that leads to contraction. Okay, so all of that is the same, and there are many other similarities. I want to focus rather on that, rather than that, I'd want to focus on the two really important differences that are relevant to what we're going to discuss here. One important difference is that skeletal muscles have polarized membranes that remain polarized unless something is done to depolarize them. And usually what's done to depolarize them is that the nerve that innervates that skeletal muscle depolarizes, fires, releases acetylcholine at the myoneural junction, and that acetylcholine binds to receptors, and that leads to a sequence of events that results in depolarization. But the point is, if you don't fire the nerve, if you don't stimulate the nerve going to that muscle, the muscle doesn't depolarize, and therefore it doesn't contract. Which means that if you denervate that muscle, if you damage the nerve going to the muscle will be paralyzed. It won't contract because it's not going to depolarize. In contrast to that, cardiac muscle has a polarized membrane, but that membrane will spontaneously depolarize and then repolarize and then depolarize and then repolarize. And there are significant biophysical and biochemical differences between the membranes of cardiac and skeletal muscle that account for that. But the point is that it spontaneously depolarizes. If you just leave it alone, it'll depolarize and repolarize. And every time it depolarizes, the muscle will contract. So that means that cardiac muscle spontaneously depolarizes and therefore spontaneously contracts. So it doesn't need a nerve supply to do that. So I'm sure you all realize that if you take a heart out of an animal, and as long as you keep that heart oxygenated and nourished, and keep it wet, it'll keep contracting. Okay, it doesn't need a nerve supply. Okay, so that's one important difference. The other important difference is that skeletal muscle cells are electrically isolated from their neighboring cell. There is no electrical communication between one skeletal muscle cell and its next door neighbor. So that means that if one skeletal muscle cell depolarizes, it will contract, but the cell right next door doesn't know anything about it, doesn't depolarize, doesn't contract. There's no electrical communication between the cells. In contrast, cardiac muscle cells do electrically connect with one another. There are membrane specializations that we've already talked about called gap junctions. Gap junctions. Remember, gap junctions are sites where there is ability for ions to cross from one cell to the other. In other words, an opportunity for communication. And therefore, that means that if one cardiac muscle cell contracts, the next door neighbor cell, if one cardiac muscle depolarizes, that means the next door neighbor will also depolarize, and therefore it will also contract. So you'll have a coordination of contraction. So that's a significant difference. So now, thinking about that for a moment, what does that mean to the heart? If we have a heart made up of cardiac muscle cells, and we know that all those cardiac muscle cells spontaneously contract, and we also know that those cardiac muscle cells communicate with one another electrically, what does that tell us? Well, although all the cardiac muscle cells spontaneously contract, that doesn't mean that they will spontaneously contract at the same rate. One may like to contract it, let's say 38 times a minute, another one may like to contract at 41 times a minute, another one might be at 42 times a minute, another one might be at 39 times a minute, and so on and so forth. So they're individual cells with their own individual rate of contraction, but they're all spontaneously contracting, not necessarily all at the same rate. However, since they are all communicating electrically with one another, that does mean that whenever one of them depolarizes, the others will depolarize. So what does that in the end mean when you put those two thoughts together? That means that in the heart, whatever cell is depolarizing the fastest, whatever cardiac muscle cell is depolarizing the fastest, that will force all of the other cardiac muscle cells to depolarize at that rate because of the electrical communication. So if a given cardiac muscle cell, if left to its own, likes to depolarize at 41 times a minute, but there's some other cell that likes to depolarize at 70 times a minute, and that's the fastest cell in the heart, then that cell will depolarize at 70 times a minute because it's driven to do that by that faster depolarizing cell. So whatever is the fastest depolarizing cardiac muscle cell, we can call it the pacemaker cells. Pacemaker cells because it's going to set the pace for all of the other cells. Well, that describes the cardiac muscle cells that are found in the sinoatrial node. The sinoatrial node is a small accumulation of specialized cardiac muscle found in the wall of the right atrium, right next to the point of entry of the superior vena cava. Specialized cardiac muscle that depolarizes faster than any other cardiac muscle. And therefore the sinoatrial node serves as the pacemaker for the heart. It sets the rate at which cardiac muscle will depolarize because it's able to communicate with other cardiac muscle cells and drive them to do that. Okay? So that's one point. Second point is, although I started off by saying that cardiac muscle cells all communicate with one another electrically, that's not completely true. What would be true is if I said all atrial cells are electrically communicating with one another, or if I said all ventricular cells are electrically communicating with one another. Both of those would be true statements. But atrial cells do not directly communicate with ventricular cells because in the heart there is a layer of fibrous connective tissue separating the atrium from the ventricle. It's called the fibrous skeleton of the heart, the fibrous skeleton of the heart. Now, it serves some mechanical function as being an anchoring point for cardiac muscle, but for our purposes now, the other important feature of it is that because it is fibrous connective tissue with very little in the way of cells or cell membrane, that means it's fundamentally serving as a layer of insulation separating atrium from ventricle. And because of that fibrous skeleton, atrial cells do not directly communicate with ventricular cells. That being the case, that means that the sinoatrial node is able to drive all of the atrial cells to depolarize at its rate, but it cannot directly drive ventricular cells. Now, if that were really the end of the story, we would have a real problem. We would have the atria depolarizing at one rate, the rate that the SA node is setting, and we'd have the ventricles depolarizing at some entirely different rate, which would be slower than that. So we can't leave it like that. That can't be the end of the story. So in order to establish some communication, we find that the fibrous skeleton, this layer of insulation, actually has a defect in it, has a gap in it, like that. It's incomplete. It has a gap, and passing through that gap, there's a bundle of specialized cardiac muscle cells called the common bundle, or the AV, or the common AV bundle, or the AV bundle, or the bundle of His, all mean the same thing. And that bundle of specialized cardiac muscle passes from the atrial septum into the ventricular septum, and thereby establishes an electrical communication between atrium and ventricle. Once that common bundle comes into the ventricular septum, it splits into a right and a left branch, called a right and left bundle branch. Each one goes down its respective side of the septum, continues down, and hits toward the apex, and then around onto the free wall of the ventricle. And so it's a pathway to rapidly get the depolarization that the SA node has initiated down to the ventricles. So now we do have a pathway. So now the SA node can drive both atrial and ventricular cells. But if that were the end of the story, we'd still have a problem. And now the problem would be that not only is the ventricle depolarizing at the same rate as the atrium, but it would be depolarizing at the same time as the atrium. In other words, atrial systole and ventricular systole would occur together. And that's not what we want. We want ventricular systole to occur a little bit after atrial systole to allow the filling of the ventricle to complete. So when the atrium contracts, it will force blood into the ventricle to finish the filling of the ventricle before the ventricle contracts. So what we want is the ventricles to contract at the same rate as the atrium, but not at the same time. We want there to be a little delay. So how do we accomplish that? Well, right here in the atrial septum, sort of at the upper end of that AV bundle, there's a group of cells in the atrial septum called the AV node, the atrioventricular node. Specialized cardiac muscle again. And there are two important things for us to recognize about the AV node. First is that the only normal pathway, electrical pathway, for a depolarization to get into the AV bundle and therefore into the ventricle, the only electrical pathway into the AV bundle is through the AV node. So if that depolarization that was initiated at the SA node wants to get into the AV bundle, it has to go through the AV node to do that. That's number one. And number two, the cells of the AV node propagate in action potential. The velocity of propagation, the speed at which an action potential will cross the AV bundle, the AV node, is slower than any other cardiac muscle. It has a very slow velocity of propagation compared to other cardiac muscle. So what that means is, if we put that all together, is that when the SA node depolarizes, there's a very rapid spread of that depolarization through all of the atrial cells, causing atrial systole. Included in that propagation of the depolarization is to the AV node, but it then very slowly crosses the AV node, slowly, till it finally gets to the AV bundle, speeds up again, and then continues down into the ventricle, bundle branches in the ventricle. So because of that slowing down of the propagation, that retardation that occurs as we pass through the AV node, by the time we get to the ventricle, it's a little bit later than when the depolarization has gotten to the atria. So because of that retardation that occurs at the AV node, ventricular systole is occurring at the same rate as atrial systole, but not at the same time. It occurs a little bit after atrial systole. The separation in time is on average about 0.15 seconds. Okay, and that's being caused by the AV node. Okay, so if we see how that all corresponds to our familiar electrocardiographic trace, I'm sure you all know that the P wave represents atrial depolarization, and the QRS complex represents ventricular depolarization. So this lag time between the P wave and the R wave, what's called the PR interval, which as you can see on this tracing is about 0.15, each box is 0.05, so it's about 0.15 seconds. That interval between the P wave and the R wave is what's being caused by the AV node. In other words, the more the AV node slows down propagation, the longer the PR interval will be. The less it slows down propagation, the shorter the PR interval will be. So the AV node is controlling the length of the PR interval. The SA node is controlling the frequency of this tracing. Okay? How many times a minute we'll see this tracing. Okay? So that's what the cardiac conduction system is. Now, recognize that throughout that discussion, we didn't invoke the word nerve at all. None of the tissue that we were talking about, the SA node, the AV bundle, the bundle branches, none of that is nerve. All of that is specialized cardiac muscle. So the point here is that the cardiac conduction system is not made up of nerve, or to say it another way, you don't need nerves for any of that cardiac cycle to occur. It will all occur without any innervation. It's autonomous. That's true. But at the same time, it's also true that the heart receives lots of innervation. Okay? There's lots of innervation going through the heart. There's motor innervation, sympathetic innervation, and parasympathetic innervation. And there's also sensory innervation. So what's all of the innervation for? What's all the innervation for? So let's talk about it one little piece at a time. The motor innervation, we said there's sympathetic and there's parasympathetic innervation. So what's that for? Well, we said that, for example, we said that the SA node will depolarize at a rate of, we use the number 70. So let's say it depolarizes, if left alone, it'll depolarize at about 70 times a minute, so that the heart rate would be about 70 times a minute in that individual. Well, if we want the heart rate to be faster than that, because of physiological needs, let's say you're out running and you need to have a faster heart rate, you need to have some way to tell the SA node to speed up. Right? So sympathetic innervation can do that. Sympathetic innervation can tell the SA node to speed up. On the other hand, parasympathetic innervation can tell it to slow down. Similarly, sympathetic innervation can tell the AV node shorten the PR interval. Parasympathetic innervation can tell it to lengthen the PR interval. And there are other functions as well having to do with the myocardial cells themselves. It's not necessary to get into that. The point is that the innervation, sympathetic and parasympathetic innervation, do not cause the cardiac cycle, but rather they modulate the cardiac cycle. They can modulate the cardiac cycle, but they're not causing the cycle. Parasympathetic innervation, of course, is coming from the vagus nerve. And the sympathetic innervation is coming from cardiac nerves that come from sympathetic ganglia T1, T2, T3, T4 primarily. So the upper thoracic levels of the sympathetic system provide from the spinal cord provide the sympathetic innervation, and the vagus nerve coming from the medulla provides the parasympathetic innervation. Now, what about the sensory innervation? Well, again, there are two pathways of sensory innervation. There are sensory fibers that run in the vagus, that go from the heart up to the brainstem, and there are sensory fibers that run in parallel with the sympathetic innervation that carry sensory information from the heart back to the upper thoracic spinal cord. Two different pathways serving two different functions. The sensory fibers that are in the vagus going up to the brainstem carry sensory information from the heart that does not reach conscious levels. It goes up to the brainstem, reaches the medulla, pons, reticular formation, those regions, the cardiovascular centers of the brainstem. These sensory fibers are carrying sensory information from the heart that are needed for the brainstem to control the cardiac reflexes. So it's sensory information that you have no conscious awareness of. Things like wall tension, things like PO2, things like PCO2. So things about the chemistry and the physical qualities of the heart, stretch of the heart, and so forth. These are all things that are needed in order for the brainstem to control the cardiac reflexes. But there's no conscious awareness of that. None of that ascends to conscious levels. The sensory fibers that are running in parallel with the sympathetics and therefore are going back to the upper thoracic spinal cord and entering the spinal cord by way of dorsal roots of the upper thoracic spinal nerves. Those sensory fibers are used to monitor the myocardium to assess whether the amount of oxygen being supplied to the myocardial cells is sufficient to support the amount of work being demanded of the myocardial cells. In other words, it's monitoring for ischemia. These are the sensory pathways that allow an individual to know if the myocardium is becoming ischemic. Well, that's something that you do want to have reach conscious levels, so that if you're out running or doing some exercise and your myocardium is becoming ischemic, you would know it so that you could stop exercising. That conscious sensation that we have that's caused by myocardial ischemia is what we call angina or angina pectoris. Okay? So angina is this conscious sensation that is being brought back to the nervous system by way of sensory fibers that go back to the upper thoracic spinal cord, and then as a result of ascending pathways to be discussed in neuroscience, will eventually reach conscious levels. The brain interprets those signals, those sensory signals, since they are arriving in the central nervous system in the upper thoracic spinal cord levels. The brain interprets them as coming from upper thoracic dermatomes. And the upper thoracic dermatomes would include the chest wall and the upper limb. And so we refer myocardial ischemic sensations to the chest and the upper limb. And so the patient will have this sensation of pain or tightness, discomfort in the chest and perhaps upper limb. Okay, so two different sensory pathways serving two different, entirely different functions. Okay, let's just take a moment to look at one issue of histology of cardiac muscle. And I want to use this slide primarily to distinguish between skeletal and cardiac muscles. So should you see a slide that contains striated muscles, since both of them are striated, how do you distinguish cardiac from skeletal? Well, at the light microscopic level, there are a couple of things to point out. Skeletal, this is a light microscopic image of cardiac muscle, and we can see a fairly distinctive branching pattern. We see that cardiac muscle tends to branch. Skeletal muscle does not branch. Skeletal muscle cells all just run parallel to one another. So if you see branching of striated muscle, you know that that's cardiac muscle. The absence of branching suggests that it's skeletal muscle. That's number one. Number two, you see that the nuclei in each of these cardiac muscle cells, the nuclei, are centrally positioned. They're in the center of the muscle cell. Okay, here, 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 here. Skeletal muscle, the nuclei are always at the periphery of the muscle. So if this was skeletal muscle, the nucleus would be here, or here, or here, but not there. Okay? So central nuclei are seen in cardiac muscle, peripheral nuclei are seen in skeletal muscle. Branching is seen in cardiac muscle, absence of branching in skeletal muscle. And thirdly, cardiac muscle have these junctional complexes at junctions between cardiac muscle cells called intercalated discs. So these dark junctions there between cardiac muscle cells, those are intercalated discs. Intercalated discs are only found in cardiac muscle. Remember, skeletal muscle is not individual cells connected to one another. Skeletal muscles are syncytiums where the cells have all fused together into one continuous cell, so they don't have intercalated discs. When you look at that in the electron microscope, here you can see that intercalated disc, this density, and it's in the region of the intercalated discs where we have the gap junctions that we talked about. the gap junctions, which remember are the membrane specializations or the junctional complexes that allow for electrical communication between cells that we talked about previously. Okay? Okay, so what we said we wanted to accomplish was to look at the anatomy of the heart, particularly the surface anatomy, and how we use that information for understanding auscultation and also how we answer questions about penetrating wounds. We wanted to talk about the development of the heart and the things that go wrong that lead to congenital defects, which we've done. Remember the defects associated with both atrial septum and ventricular septal formation. And then we wanted to talk about the blood supply and venous drainage. We looked very briefly at the histology, and we had a discussion of the cardiac conduction system and the anatomical structures that contribute to that system.